All right, today we are jumping right in to create a visual map of pediatric respiratory emergencies. What we're going to do is walk through the pathophysiology, step by step, so you can actually visualize what's happening inside a child's body. Think of this as your ultimate exam-ready guide to some of the scariest situations you might face. So let's start with this really fundamental question. We've all seen a kid with a cough, right? But what's the tipping point? What's that invisible line they cross that turns a pretty common symptom into a full-blown crisis where every single second counts?
And the answer is deceptively simple, but it's profound. It's all about size. See, a child's airway isn't just a shrunken down version of an adult's. It's completely different. It's narrower, it's shorter, the cartilage is softer, which makes it way more likely to just collapse. This one single anatomical fact is the root of everything we're about to talk about. It is the key.
Okay, so here's our game plan. We're going to start with that vulnerable airway anatomy. Then we'll head into the upper airway to look at two major emergencies side by side. From there, we'll journey down into the smaller airways. Then we'll tackle a disease where mucus is basically the main villain, and we'll wrap it all up with the absolute must-know clinical priorities. First up, we have to understand the battlefield. In pediatric respiratory care, a kid's unique anatomy really does dictate how a disease is going to play out. It's the reason why just a tiny bit of inflammation can have absolutely catastrophic results. Now look at this. This shows the problem so clearly. Get this, just 1 millimeter of swelling in an infant's airway, 1 millimeter, can slash its cross-sectional area by over half. In an adult, that same millimeter is nothing, maybe a little annoyance. But for a child, that's a massive obstruction. And you can see how the body responds. It fights. You see these retractions, the skin sucking in between the ribs? That's the body using every single muscle it has, desperately pulling to get air past that blockage. Okay, let's move on to our first big clinical showdown, and this one happens in the upper airway. We've got two main players here, epiglottitis and croup. Now, they can look kind of similar at first, but knowing the difference is absolutely critical because one of these is a true life or death emergency that can turn fatal in minutes. First up is epiglottitis. I want you to think of this as a wildfire. It's a bacterial infection that causes the epiglottis, that little trapdoor that covers your windpipe, to swell up like a giant angry cherry, and this can slam the airway completely shut with terrifying speed. And then in the other corner, you've got croup. This is way more common, and it's viral. There's still inflammation for sure, but it's usually just below the vocal cords. The biggest difference is the onset. It's much slower, creeping in over a few days, and it often just looks like a regular cold at first. And this slide right here, this is your money slide for exams. It lays out the key differences perfectly. Epiglottitis, bacterial, super fast onset, high fever. And the huge giveaway? Often no cough, because it hurts way too much to even try. Instead, you get drooling and that classic tripod position. Croup is basically the opposite. Viral, gradual, low-grade fever, and of course that unmistakable seal bark cough. So let's really zero in on epiglottitis for a second. That child is in so much pain, and the swelling is so bad that they literally can't swallow their own spit. That's why they're drooling. Their voice sounds muffled because the inflamed parts can't vibrate right. And that tripod position, where they're leaning forward, chin out, hands planted, that's not just a posture. That's a desperate physiological attempt to manually pull their neck structures open to create the widest possible path for air. Okay, listen up. If there is one thing you remember from this entire explainer, it has to be this. You never, ever try to look in the throat with a tongue depressor. Why? Well, the pathophysiology is simple. If you poke that huge, angry, swollen epiglottis, you can trigger a complete laryngospasm. That's a violent, involuntary clampdown of the vocal cords, and it can slam the airways shut for good. Your one and only job is to keep that child calm and get ready to secure their airway. All right, let's take a trip further down the respiratory tree. We're leaving the big upper airways and heading down into the tiny, delicate bronchioles. And down here, we meet two new problems, bronchiolitis and asthma. Bronchiolitis, which is usually caused by RSV, is basically a perfect storm in these tiny airways. Let's picture the chain reaction. First, the virus gets in and infects the lining of the bronchioles. Second, the body's immune system freaks out, causing inflammation and swelling. Third, those irritated cells start pumping out tons of thick, sticky mucus. And finally, that combo of swelling and mucus plugs up the tiny airways.
Air can squeeze in, but it has a really hard time getting out, which leads to air trapping, that classic wheezing sound, and a whole lot of distress.
Now, asthma happens on a similar battlefield, but it plays by a different set of rules. I like to think of it as a triple threat. First, you've got this underlying chronic inflammation that makes the airways super sensitive or twitchy. Second, when a trigger comes along, the muscles that wrap around those airways spasm and squeeze them tight. That's your bronchospasm. And third, just like in bronchiolitis, the body produces a bunch of extra mucus, creating plugs that can totally block airflow. So, how do we fight back against this? This table breaks it down perfectly. You've got two main types of drugs. Rescue medications. These are for the, oh no, I can't breathe right now moments. They work fast to relax those spasming muscles and open things up, but they don't fix the root cause. That's the job of the control medications, like inhaled corticosteroids. They're the long game. They work over time to calm down that baseline inflammation, making the airways less twitchy and preventing attacks from happening in the first place. All right, for our last disease, we're talking about something where the problem isn't just an infection or a trigger. It's a fundamental flaw in the body's own secretions. We are talking about cystic fibrosis, a condition where the mucus itself is the enemy. This flowchart really is the key to understanding CF. It all starts with one tiny genetic defect that just messes up the exocrine glands. So these glands, which are supposed to make thin, slippery mucus, instead start churning out this incredibly thick, sticky gunk. And from that one single problem, it branches out, causing blockages everywhere, in the lungs, in the pancreas, in the bile ducts, you name it. And here's where you see all that damage. In the lungs, that thick mucus clogs everything up, leading to constant infections, a barrel-shaped chest from trapped air, and clubbed fingers from chronic low oxygen. In the gut, it blocks the pancreatic ducts, so digestive enzymes can't get out. This means they can't absorb fat, which leads to those fatty, foul-smelling stools. And then, on the skin, the sweat becomes super salty, which is often the very first clue a parent might notice when they kiss their baby. So, we've gone deep into the pathophysiology of these different emergencies. Now, let's pull it all together into what really matters for you as the clinician. How do you walk into a room, assess the situation, and figure out your priorities in seconds? Here it is. This is your mental checklist. First, you listen. Do you hear a high-pitched stridor when they breathe in? That screams upper airway. Think croup or epiglottitis. Or is it more of a musical wheeze when they breathe out? That points you down to the lower airways, asthma or bronchiolitis. Next, you look. Are there retractions? Is that child tripoding? That's a huge red flag for severe distress. What does the cough sound like? Is it that seal bark? Or is there no cough at all? And please, don't forget to check their hydration. So let's wrap this up with a classic scenario. A child comes in, high fever, drooling, and leaning forward in that tripod position. You know instantly what you're likely dealing with. So what is your number one most critical priority? It's not getting an IV, it's not giving meds, and it is absolutely not looking in their throat. Your first priority is to do nothing that will upset that child and to prepare for immediate airway management. And that's the takeaway that could truly save a life.